So I'm going to end the panel discussion right now so that we can move on to the Q&A session. We already have quite a few, actually. So if Dr. Cooper could join us again, as there are multiple myeloma questions. I want to preface, though. So I will be speaking about these questions on behalf of the audience. I do think it's worth noting that us as treating physicians, we hope to offer you our general advice about these questions, but I do want to emphasize that treatment decisions are very complicated and are very contextual. So while we would happily recommend our general advice, what's actually happening to you might be much more specific to your condition and context, and the real best treatment decision is from your treating provider. So please take our answers as general answers as opposed to your specific clinical context. So with that said, first question is probably for Dr. Kelkar. Can you tell us a little bit about the neurotoxicity of CAR T cells and how often it seems to occur?
That is a great question. The neurotoxicity, as I briefly touched on, is something that usually happens somewhere in the 3 or 4 to 10 day range after a transplant, the cell therapy, and can for a patient with severe symptoms, the symptoms can actually carry on for quite a while longer than that. But those neurotoxicities can start with things like mixing up your words or getting confused. Sometimes they can look like headaches or changes to your sensations or vision or things like that as well. They're caught usually because we're screening patients along the way. We're giving them a series of usually about 10 questions that we ask them in a row that are testing their executive thinking, as well as having them write the same sentence every day to see if their handwriting is changing. Um, those are all just kind of clues that patients are getting worse in those situations. And then uh, in terms of treatments for that, as I mentioned, we often start with things like steroids. We'll image the brain to see if there's any signs of swelling, because that's usually one of the key clinical signs that patients are getting sicker faster in terms of complications. And then sometimes we'll use other treatments as needed. In rare cases, even surgical interventions are needed. But that's kind of usually what we see with neurotoxicities.
I might add too, in when we're using Carvykti, which is a myeloma-directed CAR T, there's delayed neurotoxicity as well, which can look somewhat like Parkinson's, or it can look, there's cranial nerve palsy. Those were more common with the trials where it was done later. And now that we're using it earlier, it seems to be less common. And so we're using some preventative strategies as well as using the cell therapies earlier, which seems to be improving the chances of getting that, decreasing the likelihood.
Perfect. Thank you so much. And I should clarify too, if any of the other speakers, even though I address one particular person sometimes, if any other speakers have more comments about a specific question, like Dr. Brooker had said, please join in. We welcome this conversation.